So I think Stephen will be around for questions over lunch too, if anyone has more questions then. I'm sorry, Bob, I hate to have you follow such a fantastic speaker, but you're one that can handle it. So I appreciate Bob coming here to speak about prevention in dental care. And Bob is an expert on everything, and so we call him to be the expert on everything.
Good morning. So now you're going to have another speaker with a southern accent. South Bronx. And what I'm going to be talking to you about is a highly prevalent health problem affecting young children in this county. It's the problem of dental caries, tooth decay, leading to cavities and other oral health difficulties. A graphic example of what I'm talking about. So what do we know about childhood caries? Actually, a lot more than we used to. We know that caries is the single most common chronic childhood disease in the United States. We know that it has immediate health effects that can include intense pain and difficulty eating, speaking, and sleeping. It can affect a child's nutrition and their growth. We know that children who suffer from untreated caries are likely to have trouble concentrating, they will lose days in school, and they will ultimately get poorer grades. And finally, and this is the key point, childhood caries is preventable. We know how to keep kids' teeth healthy, and prevention is neither difficult or excessively expensive. So this is one of the issues that fits into a story. And the story, to follow the previous speaker, is this is something that we have the technical capacity to do. It's a question of whether we have the personal commitment and the organizational commitment and the political will to make dental caries a rarity in Santa Clara County. There is a widespread perception that tooth decay in a child's primary teeth doesn't really matter. They're going to fall out, they're just baby teeth. Dental caries is an infectious disease. It's caused by the interaction of bacteria and carbohydrates, and in the short run, that infection produces intense pain and can lead to other infections. In the long run, early childhood caries has been shown to increase the risk of caries to the permanent teeth. So it's not just the baby teeth that are impacted, and there is also a risk of it being linked to periodontal disease, gum disease, which has a whole host of other ailments for which it is associated. All these effects, dental pain, infection, damaged or missing teeth, can have a profound effect on the overall well-being of a child and a child's quality of life. Early childhood caries can impair the teeth's developmental functions, which include the actual shaping of the child's mouth, enabling the child to eat solid food, and also the development of speech. And of course, painful, decayed, or missing teeth can make talking more difficult and actually dissuade a child from developing speech at the appropriate time. Once kids start school, untreated caries leads to restricted activities, the inability to concentrate, and missed school days. Let me assure you that these are not occasional or trivial impacts. In 2007, dental problems were the cause of 874,000 days of school absences in California at a cost to school districts of $29 million. A study of students in the LA Unified School District found that students without access to dental care were 2.7 times more likely to miss school days because of these problems. Students who said they recently experienced tooth pain were 4 times more likely to have a below median GPA compared to students without tooth pain. Now again, as I said earlier, this condition and these effects do not have to happen. We do know how to prevent dental caries. Fluoride is the foundation of caries prevention. It strengthens tooth enamel, which is the body's natural protection against caries. It's essential for remineralization, the process by which decay-damaged teeth have their enamel rebuilt. The combination of dietary fluoride, through fluoridated water primarily, and regular brushing with a fluoride toothpaste is extraordinarily effective in preventing caries on smooth tooth surfaces. The problem, of course, is not all of our tooth surfaces are smooth, and most caries today occurs on what are referred to as pit and fissure surfaces of the teeth, primarily in the back molars, where there are deep fissures that the toothbrush can't reach. So what can be done about that? Dental sealants can be used to protect those teeth. Dental sealants are clear layers that can be applied to those pit and fissure areas by a dental professional, and they create a physical barrier that keeps caries from attacking the tooth. School-based sealant programs in the United States have been associated with a 60% reduction in tooth decay. So we're looking at a condition that we now know affects learning, has potentially long-term health impacts, and is far easier to prevent than the common cold. We should be on the way to eradicating this problem, right? Not yet. We've made a lot of progress several decades ago when water fluoridation became widespread, which greatly reduced tooth decay in children and adults. But then progress has slowed. Since 2000, while older children's oral health has improved, the youngest children under age 6 have suffered a rising incidence of oral disease. Today, over a quarter of U.S. preschoolers suffer tooth decay. In March of 2012, the New York Times investigation found dentists across the country reporting many more preschoolers required major dental surgery for cavities in a third to a half of their teeth, often necessitating general anesthesia. The Seattle Children's Hospital faced such an increase in demand that 3 years ago it built an oral surgery wing. That's a national perspective. How are we doing in Santa Clara County? Largely, children's oral health problems in this county reflect the data we see across the country. By kindergarten, 21% of white children, 59% of Asian children, and 64% of Hispanic children have suffered tooth decay. Several of them include inadequate insurance coverage, lack of access to health providers, lack of awareness and education among parents, in some cases, a lack of awareness among healthcare practitioners, and a very low prioritization of the problem by policymakers. Clearly, the lack of dental insurance is one of the primary problems. Numerous studies have shown that dental insurance coverage both increases the use of dental care for children and also improves their oral health. There is no question about this relationship. The U.S. Surgeon General found that uninsured children were 2.5 times less likely to receive dental care and 3 times more likely to suffer unmet dental needs. Now, we do have some forms of public dental insurance for low-income families and those who can't afford private insurance. Medi-Cal covers dental care through Denti-Cal, and of course our own Healthy Kids program in Santa Clara County also provides dental care. but the actual amount of care that's delivered through some of these public systems is very low. In 2010-11, fiscal 10-11, dental services comprised only 1.2% of the state's total Medi-Cal budget. And among children 0 to 5 who were enrolled in Denti-Cal, only 21% actually received dental care. Pediatric dentistry is an uncommon specialty. Less than 3% of all dentists are pediatric dentists. And general dentists may be reluctant to treat children, particularly those under 3. Also, less than 50% of pediatric dentists will accept Denti-Cal patients. And those who do will only usually accept a certain number of Denti-Cal patients. It's not hard to figure out the reason for this. California provides the second lowest reimbursement rates of any states in the United States. The only reimbursement rates lower are in Florida. Also, a portion of the problem leading to children's inadequate oral health deals with a lack of awareness among parents or caregivers. Many parents are unaware of the signs of early childhood caries. Some believe that it's baby teeth, it doesn't really matter. Some assume that it's okay for baby teeth to fall out long before permanent teeth come in, and that it's not really related to any kind of health issue. And in many cases, parents simply rely on the advice of their pediatrician about all things regarding health, including dental health. The problem is, in many cases, the pediatricians may not be giving them the best information. In a 2009 survey of pediatricians performed by the American Academy of Pediatrics, only 7% of pediatricians reported that they recommended a dental visit for all patients by age 1, which is the official recommendation of the Academy, as well as the recommendation of the California Dental Association. So parents may be doing what the pediatrician is advising. The pediatrician may not be advising what is now the higher standard. Now, as you might expect, there are disparate impacts of oral health problems across the population. 25% of children suffer 80% of all missing, decayed, or filled permanent teeth. Who are the 25%? Unsurprisingly, it's low-income children and children of color. However, it's important to recognize that the most important single factor that's connected to childhood caries is neither income itself or ethnicity itself, but the lack of insurance. The lack of insurance is the key causal variable. So what are we doing to deal with the problem? Well, one thing we've done is the Children's Health Initiative here in Santa Clara County, which includes dental care, and the extensive evaluations of that program, which have happened over the years, have demonstrated that, at least in terms of healthy kids, coverage does translate into actual access to care and improved oral health. In addition, it is true that San Jose is the largest city in the United States that lacks community-wide fluoridation. The Santa Clara County Water District has approved the fluoridation policy and is moving towards implementing it. But more can be done. I would like to make several suggestions. First, we really need to focus on developing additional programs offering sealants which will protect the back molars from decay. Second, the role of physicians in dental care has to be improved. While many families don't have a regular source of dental care, the vast majority do have a primary care provider who can help educate parents, if they are themselves educated, about oral health issues and possibly help them get into a dental home. And finally, we need to develop strategies to use the Affordable Care Act to be beneficial towards improving children's oral health, and that may take some work. There are some positive aspects of the Affordable Care Act. Medi-Cal will be expanded to many more people, and that will be useful, although reimbursement rates will still be low. And it's also true that pediatric dental care is an essential benefit under the California Exchange. But pediatric dental care is not required to be embedded into the medical insurance policy that's offered under the exchange. So pediatric care can be offered as a separate add-on policy that people who buy the insurance will have to pay extra for. And it's not required. You know, everybody understands that the ACA imposes a mandate to get health insurance. Getting the pediatric dental care is not part of the mandate. So you can satisfy the mandate even if you don't have pediatric dental care. And in addition, the latest IRS rulings indicate if a parent buys pediatric dental care separately, that cost will not be used in the calculation of what kind of premium subsidy they receive under Obamacare. So that last problem is one that would lead parents to face a greater economic burden if they do choose to get the pediatric dental care through the exchange, and there are a number of major organizations that have protested to the IRS trying to get it to change that rule. Now, what would an innovative model look like that would try and be helpful in this, to deal with this problem? Well, this is a good morning for discussing programs out of the South. I'm going to describe one that's been used in North Carolina. It's called Into the Mouth of Babes. And Into the Mouth of Babes, as you can see, trains and pays doctors to provide basic preventive care. And that care can be delivered by physicians, physician assistants, or nurse practitioners who complete essentially a slightly longer than an hour AMA certified training program, and they're ready to go. The conclusion: dental care is a significant children's health issue, one that is in need of substantial improvement. It's a widespread problem, particularly for low-income children, children of color, and particularly those whose families lack insurance. It's a solvable problem. There are technical research issues that have to be resolved in order to be able to make significant progress in reducing dental caries. What is needed is organizational mechanisms, the development of institutions, the development of financing to pay for services, and the commitment of advocacy groups and community leaders to determine that, just as this county once made a decision that no child should go without health insurance, we can make a decision that in Santa Clara County, dental caries will increasingly be a rare and exceptional experience for young children.
Ernesto, you have the microphone. We have two other experts on dental care for children here, and I thought if Fred, you wanted to add anything to that, and John Fiemer with the Children's Dental Clinic, if John, you have anything you want to add. So maybe.
I have a quick edit for Ellen already to do in the health book. I wish that we could be no longer the largest city in the country without fluoride, but it's not quite that simple. What we've done and what the book refers to is the Health Trust, along with our partners First Five and this California Dental Association Foundation, we got the money and have an agreement with the wholesaler, so Santa Clara Valley Water District. They put that into their budget and their capital budget, and so they'll be moving that forward over the next couple of years. The next goal is as a water company, which is the retailer. That's who you buy your water from. And we've got to work on that next to be able to get them to agree to fluoridation. We have to raise probably about $14 million. So that's our next goal, and then once we have that done, and then fluoride would be a part of it. As Santa Clara Valley Water District does get fluoridated, there will be pockets of the county that will be brought up to optimally fluoridated water. Let's remember that we have fluoridation in Palo Alto, Los Altos, Mountain View, parts of San Jose that are San Jose Immunity Systems. So there is fluoridation in some parts. In fact, it's a disparity in the sense that we have fluoridation in some of the richest parts of our community, and then in the most poor parts of our community where you see a lot of these dental health challenges, we don't have. So it's an ongoing challenge, but one I think that is, as Bob has pointed out, caries are something that we can't eliminate. We must. We're also working with First Five and our Family Resource Center partners are doing oral health education. So we're doing lots of oral health education in people's homes, childcare centers, school assemblies. We're doing lots of work in education. And then we just received a couple weeks ago, John King, our partner for the 2 health centers, the 2 health clinics that Health Trust runs, our 2 dental centers that we've seen over the last about 2.5 years, 71,000 patient visits in our Sunnyvale and Tropicana. So we're really increasing access for kids that have government insurance, oral health education, and then fluoride. So the 3 stools of good oral health in the community: fluoride, oral health education, and access to real quality services. We're working on in this county. We're making huge headway, but we have a ways to go in terms of fluoridating our retail system. So thanks.
Yeah, just a quick add-on, just a thought for all of you to keep in mind as you go throughout your various activities is that aside from agreeing with everything that was said in terms of the scope of the problem and the nature of the challenges that we face in trying to address the need, we've always found it very curious that dentistry, probably because of the relatively small size of federal and state budgets it requires when compared to the overall expenditure on healthcare in general, it sort of gets treated as an afterthought. And as a result, there are very often very significant and very helpful and successful public health initiatives that go on around the county, around the state, around the nation, where dentistry is, for no particular reason other than just it wasn't thought about, gets excluded from the effort. And so what we're really trying to do here in Santa Clara County at the Children's Dental Centers is to be very actively engaged in community-level grassroots efforts to improve oral health. So what I would ask of all of you is when you go through your activities, keep oral health on your mind, on your radar, and look for opportunities to include us in the various efforts and initiatives that you may put into place. I was just talking here with Colleen sitting next to me from the Children's Hospital, and we were talking about the relationship between obesity and dental caries. And one of the very obvious issues when you address childhood obesity is you deal with things like nutrition, diet, exercise, and believe it or not, diet and general nutrition and the associated factors that go along with that have a tremendous impact on oral hygiene and oral health. And so there are so many different ways that these pieces can be put together and worked collectively as a unit, and we would just look for opportunities to participate with you. We have a team of people that do nothing more than spend their entire day doing community outreach. And to whatever extent we can participate and help, we are absolutely delighted to do that and looking forward to the opportunity.
Hi, I'm Liz Hunt from the Indian Health Center. We just started a portable dentistry project about a month ago. We've gone to one Head Start site. We're scheduled to go to a couple of school sites, so we'd be happy to partner with people about this. It's very exciting.
I just wanted to say that Sunnyvale School District has partnered with the Children's Dental Center this year, where they came in and did oral health screening in our kindergarten classrooms, and that's working out great. So I just wanted to say thank you so much.
I'm Arlene Getzi, and I'm a writer-researcher, and my resume includes 50 years of raising 7 children and 18 grandchildren. This past year, I have studied fluoride for the fluoridation and advise or share my information with the water board in often private meetings. What I've learned that has just shocked me this year was, though there is not water in the fluoride in San Jose ranks #1 out of 100 cities in dental care in the country, and San Francisco is 85th, who has 2/3 of its children with cavities after 50 years. And the chart I have here is how babies are overdosed with fluoride, and I've not heard anybody, and I don't think the dental profession is telling parents of babies they should not be getting any fluoride in their formula. But what really shocked me was that we are all getting fluoride in almost every bite of food we take. 8 years ago, the USDA published a chart of 500 foods and beverages, including 50 baby foods, that have fluoride in it in varying degrees. If you drink 1 cup of black tea a day, all of you have more fluoride than you should have that day. I've yet to meet someone who knows how much, including doctors, who know how much fluoride is in our food, because most of the U.S. is fluoridated, and they're processing our food, and they're irrigating our food. So our grapes, our wines, all of these foods are full of fluoride. So if fluoride had anything to do with preventing cavities, there wouldn't be a cavity in the United States. You did not mention any preventive work toward the bacteria that parents pass on to children, without which there is a cavity. So I can't even get Dr. Marty to tell me where there are any studies that say fluoride in water prevent cavities, because the ADA, all of these things on their website today say fluoride in water does not prevent cavities, fluoride in toothpaste does. That's a pharmaceutical blend or brand level of sodium fluoride in toothpaste and gels. They do fluoridate, they do help prevent cavities, but fluoridate in water does not prevent cavities, and no one is going to accept that. I can see you wanting me to stop already, but I tell you that we are getting an overdose of fluoride in this country and in our babies, and it leads to half of our teens now have fluorosis or stained teeth because they had too much fluoride as babies. So I'm hoping that somebody in this town is going to start recognizing that giving tiny babies fluoride, the first 6 months, up to 3 years, they should have less than 0.25 parts per million fluoride, which, see, I knew it. Everybody cuts you off when they try to give you the level and the truth about fluoride, and they accept what has been said. Please, go beyond that. Do your own research and find out.
I just want to make one comment there. As far as I know, no one has made any progress in finding a way to eliminate bacteria from the human mouth. You're not born with it, but you get it within the first 3 months from somebody, probably from your mother. And once you've got it there, I don't think there is any prospect of ever being able to remove it. I mean, you've got more pathogens in your mouth on any given day than there are humans on the planet.
That water fluoridation is very controversial among many parents, and so I think that is a really important question to address. Is it really something that's necessary for every person? I know from my experience, I'm one child of 4 in my family, and I grew up in an area where we didn't have fluoridated water in the beginning, but then later on, only one of my siblings took supplemental fluoride, and she did end up getting the white spots on her teeth, and all the other kids that were not given fluoride didn't get it. And so I wonder if there's more like a nutritional intervention, or, we were all breastfed, so maybe is it dietary? Are there other issues as well that are, possibly we could educate people about in the public?
So you can, avoid having, as the child gets older, sugary beverages and sweetened carbohydrates and other things that will contribute to tooth decay. That's an advantage. If you can get, if you don't want the child to ingest fluoride, but you want the benefit on the teeth, you can get a fluoride varnish directly applied to the teeth once your baby has teeth. You can have sealants put on the molars to protect against cavities. So fluoride is viewed as one of the major weapons against dental caries, but if you choose not to use that one in your arsenal, it's not the only weapon in the arsenal, and there are other things you can do that will be helpful. Yes?
I was actually in attendance when dental professionals, and the biggest name in dentistry, excuse me, I don't remember his name, Fred would know, gave a presentation to the Santa Clara Water District about the research on fluoride, and I would say it was overwhelming. This is kind of like climate change. It's a very small group of people who say, oh, no, 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 no. But the overwhelming number of professionals and researchers back up adding 0.7, it's a very small amount, into the drinking water. And the fact is that we're talking about families that this is the lowest cost, most effective way to prevent dental caries in small children. And I wish that my son had had this, because he grew up in San Jose, and I was supposed to give him those little tablets, and I kept forgetting, and now he's got a mouthful of cavities, and myself, and I'm, college educated, so what about all those parents who can't get their kids to the dentist, or who can't remember this is a public health issue, and adding fluoride to water has been considered one of the big successes of the 20th century public health. Thank you.
Okay, I'm sorry to interrupt. I know this is a very complex issue, and so we just want to thank Bob for his presentation. My name is Emily Hennessy, and I'm actually standing in for Kathleen King. She actually had to step out, so she apologized. So she's asked me to introduce the next speaker. So our next speaker is Dr. Rosanna Rogers, and she is the Department Technology Lead for Kaiser Permanente. Welcome.
So first of all, thank you very much for having me here today. The goal of my talk today is to present parts of Kaiser's integrated healthcare model and how we use that integrated model and the technology that we have to improve the care and health of our patients. So in order to demonstrate that, I'll be going over parts of our integrated healthcare, parts of e.org, our online website, parts of My Doctor Online, which is our program for our physician homepages, and a preventive care application that we have for phones and tablets for Northern California Kaiser members. So to start off, our integrated healthcare medical record system allows all doctors and providers to see each other's notes, evaluations, lab results, and that way to provide a comprehensive, consistent care plan for our patients. We also use the information in our medical records to kind of provide prompts for us as the healthcare providers, but also prompts to the patients for directed health care to optimize their care. We also are able to utilize this technology for personalized email messages to follow up with patients, to help follow up and provide reminders. So one example of how we use our system is in our electronic medical record. Part of every WellCare child check, and annually every year for children, we want to look at their body mass index, also called BMI. BMI is a way that we are able to standardly look at weight for height for children based on age and sex. Goal is 5 to 85%, but there's standardized charts for age and sex. We're easily able just to click a little BMI button that pulls in the information that's already been calculated from the child's height and weight for BMI. It puts in to the note the BMI information, but also puts into the patient visit summary for the patient what the BMI is, what the goal is, and healthy habits to maintain a healthy BMI. So the 5 fruits and vegetables a day, hour of activity every day, and no sweetened beverages. We have these patient prompts that kind of simplify it to give good care and reminders, but also there's a prompt for me as the doctor that the BMI is due. There's prompts that come up if vitals are different than they've been in the past or out of normal range, and these prompts appear for the patients when they look at their medical record online. Through this system, we're able to utilize our online resources. So I can look at my schedule and see that I've seen a new member, and I want to send them a follow-up message just so they know how to reach me, who to call in the middle of the night when their child's sick. Or if I saw a patient for some complicated issues over the visit and I want to make sure that we have all that action plan clearly outlined, I can clearly click on my schedule for a follow-up secure email message, so that FUSM, or a future secure message if I want to send a patient follow-up, oh, you were in for an ear infection with Timmy 2 days ago, I want to make sure that Timmy's feeling better. Can even use it for patients who need reminders because they're doing alternate vaccine schedules and we want to make sure that they don't get further behind than they already are. It easily pops up, so I have 6 messages that I have saved for new patients, a patient I haven't met before, common problems like colds or stomach bugs, or like emergency room follow-ups, which are a big deal for patients. Through these, you can see on the left kind of upper corner, I can pick when the patient is going to get this message, but on the right-hand side can pick also to ensure that I receive a message if my patients haven't gotten the message. We also have a number of resources through our mobile online site, kp.org. So kp.org allows patients and families access to lab results, immunizations, after visit summaries, but it also promotes patients being actively involved in their care. So it makes for simple ways to refill medications, book appointments, or email their doctor. So here's an example of the kp.org cover page. Welcomes you by your name, but you can also link to your family members through here. But it gives you the options of going through the health record, booking appointments, the medications, all the options I talked about. You can see towards the middle, for adults, it has options of total health care assessments and wellness coaching tools online. There's also the options of an extensive database we have on health and wellness. So able to review a wide range of topics, and this is available to everyone in order to cover as much information and provide reliable resources to our patients. Once getting into the medical record, on the right you can see the option of looking at allergies, your health summary, medications, upcoming appointments, test results, and also preventive health services that you or your family members are due for. Like that BMI button that I was looking for checking in and kind of covering those healthy habits. It also gives the option of booking appointments, so patients can directly, as you can see in the bottom half of the screen, book appointments for a well child check, for injury, for an illness, or optometry services. Trying to provide a direct, easy, simple way for families at their convenience to provide care. We also have our email system, so when you kind of go through the prompts to get to the email, patients are able to select their primary care doctor or other physicians that they've seen in the last year to email about questions or concerns. And patients also through here can attach JPEG and PDF documents. So I've had families email me, here's a picture of my child, is this their normal eczema and dry skin? Do I use this medication or that medication? Provides efficient care, gives documentation, but avoids the office visit when it's not necessary for the family. I've even had families kind of use this to email me camp forms or school forms, so it's one less visit to drop it off to the office. Patients are also able to look back, just like your normal email inbox, at what messages have sent back and forth. So if they're like, I know, especially for the younger ones or when kids are sick, parents are kind of sleep deprived, and memory can be a little rough, so it gives a good reference as to what we talked about or when to follow up or concerns to follow for. Another online feature that we have that works on desktop but is also mobile compatible is our My Doctor Online. So our My Doctor Online web pages are our home pages for each of the physicians. It allows patients and families to connect to kp.org, review physician information and background, review health topics, and these health topics are picked for each department. Also utilizes classes, tools, and resources available through kp.org. So I'm just showing an example of my own homepage. On the right-hand side, there's quite a number of options that's connecting to all the kp.org features that I already mentioned. My general greeting at the top, also the direct number to call. So if you're on a phone, can click that to call our appointment and advice line right away. On the left-hand side are our quick links. So this also provides resources that are picked by the department and physician for useful outside resources or internal. So there's like a Tylenol and Motrin handout sheet, dosing sheet for the little ones, but there's also links for information about vaccines or allergy season, cough and cold season, or when to worry about fevers. Here's just an example of how My Doctor Online looks on a mobile phone. So you're able to get the doctor information in the first one, look at the office information, so the phone numbers, hours, contact information, further resources, and connect to all those kp.org features. All of our health topics, too, often include outside links, links to other Kaiser resources, and several like this have podcasts and interactive tools for families. Some of the outside resources we use, a lot of families are online now and looking for information, so it's all validated, trusted resources like the American Academy of Pediatrics or Centers for Disease Control. Here is an example of our health tools and classes, and it's broken up by categories because one long extensive list would kind of get lost, but to try to increase the convenience, we've got options for babies, infants, teenagers, health and wellness. Another interactive example of tools, we've kind of worked together with our orthopedic doctors, our physical therapy doctors, that we've got patient interactive tools that we keep expanding for pain problems. So not uncommon to see a teenager with low back pain, either from sports, hunched over a computer, heavy backpacks, variety of reasons. But this gives another interactive tool, easy for me to give them the link, and they're easily able to find this from the My Doctor online pages, and able to walk through, here's what you should expect. Here's videos of how to do those stretches your doctor told you to do at home. This allows patients to sign up for push notifications for themselves and family members for preventive health alerts. So for kids, your child's due for a well checkup, or they're due for their flu vaccine, but also adults for like colonoscopies, mammograms. Gives appointment reminders to families. Patients can view on the go information about their doctor and locations, and provide seasonal health tips. So here's just a feel of the preventive health app. It shows kind of family members. You can see your family members and what you're due for. Can click in when it says, oh, you're due for this, and you're like, I don't know what this is. Further details about why this is important, what it involves, but also to schedule directly. So on your phone, while you've got some downtime waiting for something, to get your health care and get yourself in, keep yourself in good health, and shows kind of scheduling appointments. On appointments, it'll show you in the appointments tab what appointments you do have scheduled. It gives you kind of looking to see, oh, here's who I've scheduled with, here's the doctor, because sometimes keeping track of our names without a face is not as effective. But also gives the options to call or reschedule, to cancel, or to search and directly get on your phone how to get to your doctor's office. Again, more kind of showing you can see your personal doctors, so doctors who are providing regular care to you and your family, their information, and can also look for facilities. So my doctor ordered some labs for me to do. I have time this weekend, but I don't remember what offices are open or which one's the closest. It also will send out personal health tips. So periodic, healthy eating, active living. In the winter time, cold and flu information. This time of year with the allergies kicking in, allergy information. But once you get into that tip, it provides further details and resources. It lets you also share this information with other friends and family, kind of through the share this by email, or can call Kaiser for further details if you're like, oh, I didn't think this was a problem, but I have further questions, or I'm realizing something more might be going on. There's also the Click to Call Wellness Center coaching. So I I just wanted to review, a lot of this talk was just trying to review kind of the technology that we have in the Kaiser system and how we're able to integrate that technology to provide the best care for patients, whether it's optimal communication between patients and kids' different doctors, so the primary care doctor and the specialist, or the doctor who saw the kid for a sick visit. But it also provides personalized care and prompts from the doctor and for the patient, but also to the patient, to try to motivate families to help their kids along. Provides instant access and fingertips for health records and how to get access to your doctor and to our services on the go or at home. And for the next slide, we have kind of a perspective video just trying to show not all features available now, but in the future, how it's so important in medicine to utilize the technology and resources we have to integrate the care and provide that personalized, in-depth service to our patients. I wanted to thank everyone for your time and attention.
That tells us all how much Kaiser is advanced that we could even think they have all that already, but they have a few more years to go. So now it's lunchtime and we have very healthy food.
I am a dietitian that works at the Pediatric Healthy Lifestyle Center, and it's through Valley Medical Center. And it was founded in 2003 by a passionate doctor, Dr. Delgado, who's our first director. He was noticing that there was a lot of children who were very sick, and it wasn't just obesity that he was concerned about. He was concerned about comorbidity or lifestyle-associated things that could be prevented, like type diabetes, type 2, and high cholesterol, high blood pressure. And he was just very concerned. He tried it as a pilot test, and his pediatricians responded very well, and we became an actual full-time specialty practice in 2006 for Valley Medical Center. So our vision is promoting health and fostering healthy lifestyles for Santa Clara County's children and their families. And our mission is to do it by providing high-quality, family-centered, community-linked preventative care, lifestyle management and medical interventions for the children and the youth at risk for type 2 diabetes and other lifestyle-related conditions. We are comprised of 4 pediatricians, but if you notice there, they're not full-time. And we have 2 dietitians on staff. I am the second dietitian that came on board. And we have a nurse practitioner, and we have a social worker and mental health that we do work with. And we have a great administrative assistant who does amazing with all the referrals and billing. And we have 1 medical assistant, and we use a lot of extra help. So we are a little bit chaotic. Most people think of us as a program, but we really more function as a center. So we work in the clinical setting. Dietitian and doctor work side by side together in seeing our patients. And we are, primary care actually refers patients to us as early as 9 months, but most of the time we see 2 and older. And if they do come younger at an age, it's for usually elevated or off balance weight and height. And children who are also have high cholesterol, like I was mentioning, or prediabetes, or have a high family risk of that. We work primarily with low-income families. So I spent probably 80 to 90% of my day speaking Spanish to families that we see. We have our guiding principles that are evidence-based, and you can see those on the 2007 American Academy of Pediatric recommendations. We have converted them into the 10 healthy steps, which you see on page 30 of the booklet. And those are our guiding principles. Those are the consistent evidence-based messages. And our approach is that we are asset-based, meaning communities have a lot of strengths, and we are fortunate to work in the county of Santa Clara because we are, obviously, as we see, there's a disconnect in some of the programs that exist within the county that are helpful to us and to everyone around us. We also have the belief that families do want to be healthy. And I think that sometimes we don't think they do, but they come in wanting to know that information. However, they lack the tools, the skills, and the resource to be able to make that happen for the families. Not to mention, in our case, we see a lot of immigrants who don't have the language capacity. And we also are community links. So our program has resources or collaborations with our community, like YMCA, where we offer scholarships. We also have Turning Wheels for Kids, which is a nurses program through Valley that we collaborate and give bikes for physical activity. And what's unique about our program is that we're very, very, very extremely family focused. What does that mean to us? That means that in the room with the doctor, with the dietitian, myself, I could have in there parents, grandparents, aunts, and all the siblings within the room, and we love it. We love it, we encourage it. We think that's the best approach because everybody hears the consistent messages. Everybody is a piece of the puzzle. Everybody is a piece of the team. And it really takes the pressure off of the child that they are a problem as far as weight. And it reduces conflict because a lot of the times parents, they're in the bickering, the struggle, he does this, she does that. And so when we work together and they're hearing it both from the physician and from the dietitian, then we notice that there is a change on talking about how we can all be a team. Now, more closely on our approach, we are not weight focused. And the reason we are not weight focused is because we believe that it is a conversation, first of all, non-starter. And a lot in the Latino population, they don't care about weight until 6 to 7 years of age. That's when it becomes evident for the parent that raises a concern to the pediatrician. Usually the other way around, it just earlier than that, it's not something that they are very worried about. They think of health in a different way. They think of it as, are they smiling? Are they happy? Do they have friends? Can they move? And are they happy? Are their tummies full? Very, very different. And so we like to just de-emphasize that and not focus on diets, focus on the family, what the family already eats. We do not take any cultural foods out of their diet. We enhance it, we substitute, and we work with the cooking methods. We also don't use the word exercise within our clinic. Exercise is a word that we do not like. Children are meant to move, and they already know how to do it. So we use the word play quite a bit, and we try to match whatever fun activity they like to their child and their family and the resources around them. And we believe in the no deprivation model, meaning families will focus on changes, and we always say in Spanish, poco a poco, little by little. And whatever the family is ready to do, we work with them. And then we figure out where are they getting stuck and how can we push them forward without them feeling that they're deprived and anxiety increases in behavior change. So how do we translate that into what the project that we're working with? And that is building capacity. How do we take the 10 healthy steps and build capacity into child care providers? So back in 2010, I did a little bit of research that was published specifically on this group. And there is a strong need. We have a lot of people who are working. They share the responsibility with their child care providers. They're very connected. They want their children to be healthy. And the continuing happens there. It's a shared responsibility. So we've done that. And I was teaching on Saturday, all day training for them. And it was beautiful because there was a lot of things we don't know about where they get stuck. And it was like kind of a little bit needs assessment. So although we were able to teach, we also learned a lot from them. So we learned a lot that a lot of people know what. If you ask a 5-year-old when they come into the clinic and you say, what is healthy? And they're very cute and they'll tell you fruits and vegetables. Right? You're like, you're a dietitian and you come in here but you're not talking about nutrition. They already know this stuff. Really, my work is that how does that happen for the family? Where are they getting stuck? That's problem solved. And so that's what we've done. So our content with our program is, again, de-emphasizing weight and body shape. Make the connection that habits determine your health. If we get on the scale, it's not the weight's fault, right? Really, it's that we need to look at where are the roots of the problem, and that's usually a habit. It's usually a habit that we're not doing or a habit that we are doing. But the habit in reality needs to be changing in order for us to determine the effects of health, which may or may not help our weight. We also acknowledge that our environment has changed, and it's making it harder and more difficult for families to be able to be healthy. And that lifestyle recommendations are for all children. But going back to the environment changing, this one's actually kind of a little bit interesting because when we present the 10 healthy steps, they think of it as a diet. They think of it as something that is not normal, that is difficult to do, who's doing this. And so one of the things that I will go to is I'll show you a couple of the slides from the actual presentation is I ask who's healthier, ¿quién es más saludable? Just by looking and being able to capture that looking at someone, you're not necessarily able to tell what habits are helping their health in the future. And, I think it's a big aha moment for our families and for the child care providers. One of the other things that I show is this one on how it is becoming more difficult with our environment. And that it's more difficult to be physically active. Kaiser just showed beautiful how we use technology, but technology is also affecting us on our physical activity. So it's how do we help parents with a parenting technique that wasn't necessarily something that our parents had to do 20 years, 30 years ago, and is finding that perfect balance that will help them do physical activity. Well, the child care providers is the same. How do we focus a routine? How do we take some of these foods out? And one of my things is we got to go back to basics. We want to go back to the basics for the 10 healthy steps. We have to also go back to the basics, how to teach and how to educate and how to connect with our public. Notice I don't have anything fancy. I don't have technology. You know, it's really interacting with them. It is a simple presentation that I gave with experiential activities for the child care providers as well as the parents. We have to really reevaluate the way we think about health. You know, we had a big segment about a year ago, right, weight of the nation, and I get frustrated with that because I'm trying to make a change into health of the nation. We are forgetting about key habits that are not being reviewed, and that's what's affecting us. In the way we educate our community, we have to think that way as well, and think simple, logical steps. So we came up with this. Where step one is your home food environment. We need to help families identify what foods are not helping them be at home. And it's so important. Their marketing is so strong. If we see some of the children who are watching TV, they're watching more commercials, they're influenced as a parent when they go shopping. This population shops a lot more. They shop 3 times more often than the average American. They are taking their children. It's a family engagement. And those are the things that we're missing when we're doing and working with this population. It's like this elephant is in the room, but we have no idea how they function, what they do, how they think. So learning how to do the home food environment is going to be helpful. Literally, I show pictures of what I showed before and what determines health because they're visual learners. And that's how simple and how basic we need to go back to. Step 2 is menu planning. Mi Plato works very well, but some of the dishes that are culturally based don't work like that. They're very mixed. They're caldos. They have vegetables. They have protein. So it's a difficult concept sometimes to incorporate. On meal routine, we know that this population is highly disorganized. They have a lot going on. There's a lot of mental health. So letting them know that this is going to help them. Yes, there is going to be a huge learning curve. It is going to be more difficult. But in the end, the stress reduces for the parent, and they actually really love routines. And going back to child care providers, they love it. They have this expectation that child care providers will be able to do that. Now, whether it's a skill that the parent can do once they get home, that is where we come in the Pediatric Healthy Lifestyle Center. And then as far as making meals pleasant, this one, we do incorporate division of responsibility here, how to de-emphasize how much they're eating and focus more on the quality of the food that they're actually purchasing, presenting, offering on the plate. And then last but not least, relax and playtime. It's amazing how much sleep is needed. The National Sleep Foundation has great information on that. Parents need to be told how many hours. Most parents that we see think 8 hours is enough for a child that's 2 to 4 years of age. They're sleeping at 11 at midnight or even 1 in the morning. So pediatricians could help with that, yes. But pediatricians don't have time to cover everything in a 15-minute visit, and that's why they ship them out to the Pediatric Healthy Lifestyle Center. Early child care centers do a great job of nap time. However, they also notice that children are very tired, they act out, they notice the symptoms. However, parents do not know the symptoms of their child not getting enough sleep. And they don't realize the repercussions and the consequences of media, of little screen TVs, and how that works with the eye, which Stephen probably would know more about it, but you know, they don't know that, they don't realize that that wakes them up. And so we've incorporated these 5 steps using the 10 healthy steps in a way where it's an approach of how. What are the first step, the second step, the third step if I was a parent. Now when we do it at the pediatric child care centers, Pediatric Healthy Lifestyle Center, we meet the parent where they are because some of them have already done certain steps. But when you're creating a curriculum like the one we're creating for child care providers, we don't know where they're at, so you have to start from the beginning. And if they're already doing some of these steps, then great. And then let's just focus on the steps that maybe they haven't had time to focus on, or they didn't know the skills or the tools or how to do it. So we're very, very excited. We have a 3-day training. We've just finished the first day. They have take-home activities, and then on the second day, we will be asking them what were their challenges, what were their struggles. We will be problem-solving since it is a pilot study. And then a month later, they have again an opportunity to use it at home, for another month, and then have us as a resource on the third day to be able again to problem solve and how do we maintain these habits and how do we relay this information to parents when we're not pushing the information as child care providers, but offering as a strategy that once again we have this team, this collaboration of shared responsibility to create healthy habits within children and be able to foster that. So with that, I will turn over to questions. I do have flyers if you're interested about the Pediatric Healthy Lifestyle Center. We're always wanting to collaborate with physical activity people because that is probably our number one thing that parents do have a hard time finding is physical activity that is economical, physical activity that's within walking distance, physical activity that is in the evening because parents work, and physical activity that we see that parents like and that children love is soccer. There's this huge, huge soccer community. So thank you very much. I will be here and answering questions.
For a family to get connected with your center, do they need a pediatrician referral?
Yes, they do. They need a pediatrician referral, and I think it needs to go into Valley Express, but I can give you the flyer. That is also the phone number, but I can give you the flyer on the steps.
Okay, and can a parent ask to be referred to your guys' center?
But of course, they're very connected. Carol Danaher has gone to many of the community docs that part of the Valley system. They have Kaiser we're currently I do not have a connection with. Kaiser does have some of their programs. I know Santa Teresa has one. I know San Jose has a program. They work a little bit different. I know the one in Santa Teresa, Allison Collins, she actually has rotated through our program and has similar components to her program. But yeah, Kaiser has a couple of programs.
It was really exciting Saturday when Karina was doing teaching the daycare providers. You could tell they were really into it. They were sharing ideas. I think, Karina, the one you didn't cover was, I know it was a big issue with agua fresca. So trying to get, where they think, it's not that bad if you have it a little bit each day, but Karina talked about the cumulative effect of something like that each day.
Yes, it's a very cultural thing. Yes, we have a lot of families. Believe it or not, the Pediatric Healthy Lifestyle Center, we do ask families to take aguas frescas out. And it's not that they can never have it. So our philosophy that there's everyday foods and then there's sometimes foods. And they really get that concept that aguas frescas weren't made for every day. It is something that is tasty. But if we think about our ancestors weren't drinking aguas frescas every day. So it's something that they can have, that they can occasionally make, but especially in child care providers, we want the parent to be able to decide juice. That was another controversy, 100% juice. Well, WIC offers it. Well, American Academy of Pediatrics, it's inconclusive messaging. Well, really, our philosophy is that it competes. Aguas frescas compete with regular water. Aguas frescas competes with milk. Juice does the same thing once we have it in home. And for those who are parents, if a child knows that there's in the refrigerator another food that they highly is palatable and they really like it and they want it, and they're going to drive you nuts. Mommy, daddy, no, I don't want that one. So by being able to talk about it in a way where it competes, it's a very effective message. We also presented and modeled the food that we provided for them, and we offered them water with cucumber and some mint. Absolutely loved it. They had no idea that there wasn't any sugar in it, and they wanted to know how to make it. So what I like about child care providers are willing to be adventurous into trying different things, and parents as well. And what we find the challenge with parents is that if dad's not there and he's working and dad wants the Coke and dad wants the aguas frescas, and it becomes a little bit more complex. It doesn't mean that the habit doesn't change. It takes 3 to 6 months longer. However, dad comes along or we get him into a visit to come with us, and that's how we support the parents. And I think the child care providers are so ready. They let me know that the parents are wanting, they have high standards. Parents have really, really high standards, no matter if you're in Cupertino, no matter if you're in the east side of San Jose.
And that's great for them, and that's why they're in this training, and they want to elevate their business, they want to be able to support parents. And if we work on the parent piece and then the child care piece, then it just becomes this beautiful shared responsibility on how to create healthy habits and raise healthy children versus focusing on the weight.
I know we all have started looking at sugar content, but I went through Karina's class, and you know the little box of apple juice? I think it has 8 apples in it. So 8 apples. And so how many kids could eat 8 apples? How many of us could eat 8 apples? That's what you're getting in that juice. So their advice is just eat the apple instead of the juice. So I think it's going to be an excellent program. We're real excited about it. So you're down to the very end, and I will try and go through this pretty quick, but I do want to point out a few things in the data book. So one, Jennifer, who's not here, and Emily worked very hard to make sure on each page where the data came from is listed. If it's kids data, if it's census data, if it's California finance data, so that you can go further if you want. One thing that's very hard to do with the different data sources is the age banding. Some go from 0 to 17 and some go from 0 to 19. So you have to be very careful when you're looking at the data to look at what age group we did. So I'm going to go through this pretty quick. I just want to point out the key points. On the cover, it's the 3rd annual. You'll see that under Stephen's name so you don't get it mixed up with previous years. You can skip and go to the page number 1. My only points there is we tried to make the point that healthcare for children in this county is probably 10 years ahead of Obamacare, in that all these children are in managed care. They have a lot of the preventive care that hopefully will help adults. And in case you don't know, Obamacare is really focused on adults. Because if you think about it, in all parts of the United States, children are covered up to 250%, and in our county up to 300 or 400%. Obamacare is up to 138% for expanded Medi-Cal, and then 138 to 400% for the covered in the exchange, versus most of those kids are in some program or have some program right now. As most of you know, we were the first Healthy Kids. Bob Brownstein was very involved with PACT in putting that together, and it's kind of that same approach, no wrong door. Come in, we'll find what you need, and that's what I think Obamacare will be in the future. But we really had a lead in being the first county to do that. If you go to the page, we always like you to look at the page with the sponsors so you can know who has helped put this together. And I would like to thank again, we have Blanca Esquez down here, and Maricela, Emily, Renee Maria over here from CHP, and Margie Kane that helped all day, Ernesto from my staff as well. So I think if we could give them one more round of applause. They each take notes afterwards for what we can do better. So we've gotten a couple examples, appreciate it. If you go to page 3, Renee helped us put this data together, and you're really seeing by city what percentage of the population is children. And I think this is somewhat helpful to look at, because you'll find the areas where the poor people are tend to have a higher percentage of children, or the areas known as having really good schools. So you will see Cupertino's at 29%, Gilroy's at 32%. The one that always surprised me was Mountain View. They're up a little bit, but they're at 21. You find more of the young workers there. The farthest right column shows what percentage of those children in those cities still don't have health coverage, and that's up to 400%. And if you look at it as 400% sounds like a lot of money of the federal poverty level, it's as if 2 parents are making $23 an hour and have 2 children. It's not a lot to live on. You'll see later in the book how hard it is to live on that amount. So if you go on to page 4, what I think is most interesting here is compare California to Santa Clara County. So if you look at the boxes of data, the Latino population in California is 51.6%. 1 out of every 2 kids in California is Latino. But in our county, it's 36%, so just a little over 1/3. The interesting part is, for us, our Asian community of children is almost 1/3. So when you look at the total population, you don't see this. When you look at the children population, you get to see the trend occurring in our county. If you look at the Asian population in California, it's 11.2 versus us at 31.3%. The next page, 5, I find fascinating. Again, I'll look at the box of data. The Latino children, 42% live under 100% of the federal poverty level. So that is as if one parent was working in a family of 2 parents and 2 children, and the one parent is making about $10 an hour. Very, very hard to live on. But then 42.7% are above 300% of the federal poverty level. So we see that broad difference in our own county. I think that's the important thing on that page. On the next page, I think that if you look at page 6, I think it's fascinating to see how our birth rate is dropping. So in our county, since 2004 to 2010, our birth rate has dropped 10%, versus the states has dropped 6%. But if you look at the different ethnicities, you see a drop in Latinos, and then you see it flat, but you see a growth in the Asian birth rate in this county. I just think it's interesting to note. If you look at page 7, I think this is one of the most exciting pages. I don't know that Julie's here from Planned Parenthood, but this is really working with trying to reduce the number of teen mothers we have in our county. And it's been a very large drop in almost every ethnic group. Now, if you look at the right side of the page, that column of information, I think in 2010 in the United States, almost 1 out of every 5 teenage mothers has more than 1 child as a teenager. And some even have 2 children. And you can see in the Hispanic population, there's still 1 out of every 5 teen mothers is Hispanic in this country. The next page 8 is really looking at the self-sufficiency standard. I think this is important in our work to always look at, because federal poverty level means nothing in our county. But in essence, thank goodness for those that worked on the minimum wage in San Jose. The next time you see this chart with a $10 minimum wage in San Jose, it will take 4 workers to meet the self-sufficiency standard for 1 parent and 2 children. So it really shows that a lot of social benefits are required by our low-income families. And if you look at the last bullet, 31% of jobs in Silicon Valley paid less than $16 an hour. It's pretty. And a third of our households don't bring in enough dollars to meet the self-sufficiency standard. The next page, page 9, looks at it for a family of 4. And I thought it was really important to look at the difference between a set number of years, 2003 to 2011. Taxes have almost doubled, child care has almost doubled, and health care has gone up 80%. For a total cumulative increase between 2003 and 2011 to live in this county is costing families a third more than they did in 2003. All this data came out of the Working Partnerships book. The next page, 10, is health coverage of children 0 to 17. And I think next time we will do this, this was my mistake, we will put what percentage don't have health coverage. But this is something we can really be proud of in our county. The Health Trust has been a big part of this PAC. But we have only 7% of our Latino children don't have health coverage versus the state is 12%. And Asians, only 3% of our children don't have health coverage versus 7% in the state. And the next couple of pages, pages 11, 12, break down by 0 to 5 and 6 to 17, which shows what first 5 has been able to accomplish. The 0 to 5 have much lower uninsured rates. But the sad thing is, if you look at this data closely, the 0 to 5 children, actually more of them are being born into poverty than ever before in this county. Page 13 just pretty much covers what has happened with Children's Health Initiative and Healthy Kids. Frankly, often I have to explain this, and so I put this in because now I have the data quick at hand. The next page, 14, shows the growth. We've left healthy families separate because it's nice for us to look at it that way, but the growth of Medi-Cal healthy families and healthy kids. It's, you know, a third of the children, there are 452,000 children in this county, and a third of them are in one of those programs. Page 15, these papers from Mathematica have been out for a while, but if anyone wants to ask you what health coverage does for children, if we can show that children miss less school, that half of them no longer are missing 3 days a month, a day of school in a non-basic aid school is at least the cost is $35 to $40. So that school does not get that money, at least $35 to $40, if the child's not in school. It's one issue. If children don't have health coverage, it's proven data. It's been peer reviewed that they miss more school. The actual cost for healthy kids is $86 a month for philanthropy. But for those children who miss 3 days of school, that's at least $105 to that school. So the cost of the school system is higher than the cost of the program. The next page, Emily, who's excellent at this, gave us kind of a cheat sheet on what will happen with Obamacare. And I think it's important we all can state this. I think we need to know the basic numbers. Expanded Medi-Cal will go for an individual, single adult, up to approximately $15,000 a year. So an adult that makes under $15,000 a year will fit within Expanded Medi-Cal. If an adult makes somewhere between, well, let's then take, oh, I'm not going to get this right either. For 2 adults, it's $21,000, and for the exchange, 2 adults will be up from $21,000 to $62,000. It's kind of important to know where they fit, but what the slide is trying to say is there isn't much in the package in Obamacare, except for our children, who will now be covered up to 27 years old. I mean, I think that's important, but for low income, the gap is just that those children between 300 and 400% of the federal poverty level will fit into the exchange. The rest all fit into programs right now. There's no reason they shouldn't be in something. On 17 is about the concern about prenatal care. 1 out of every 5 Latina mothers receive late or no prenatal care in this county. Very upsetting. The next page has quite a bit of data on prenatal care and Text for Baby. I hope everyone knows about Text for Baby. When you find out you're pregnant, you go into Text for Baby. You just text it and you put the date you're due, and they will tell you, they will send you texts free doesn't cost your provider, you don't have to pay for it, and it will send you texts that say when you need to get certain care. When the baby's born, you tell it the baby's born, and it will give you what care is needed for the next year. So frankly, we all should be checking it out and making sure it covers everything we think is important in a text for a baby. The next one has been, First Five has put a lot of time into getting this information out to families in our county. These are children that die in their first year, not due to drug use or alcohol or anything with the family, but being in unsafe sleep environments. And you can see in the red below, 7 more children died in unsafe sleep environments in 2012. And SIDS, sudden infant death, is almost gone. There have only been 2 infant deaths since 2005 to 2011 that are applicable to SIDS. The issue is unsafe sleeping environments. And if you've ever talked to one of these families, this is hard to do. Many are used to sleeping in a bed with everybody. And then there's lots of comforters, and it's just one of the saddest things. On page 20, I think it's important for us to have the visual of what a newborn tummy looks like at birth, the size, and the size after 2 weeks is like a walnut. That's why mother's breast milk is so good, because you're not as likely to overfeed your baby when you're nursing. If 90% of families breastfed exclusively for 6 months, nearly 1,000 deaths among infants could be prevented, saving the U.S. $13 billion per year in medical care costs. I believe El Camino Hospital has one of the highest percentages of any hospital in the United States. I think I read that. And that is due, I believe, to El Camino and Palo Alto Medical Foundation working close together. The next page is on asthma. We, in the Latino community, we have a higher percentage of children with asthma than the rest of California. I don't know if that's the poor areas. We haven't really delved into this more. There's lots of information. San Jose Unified did a very interesting study, if anyone wants to see it, on combining healthcare with nursing staff at the schools, and found they were actually able to reduce the number of children going to the emergency room for asthma from 1 out of every 2 each year with asthma to 1 out of every 6. And they were actually able to prove that the grades, that the testing scores went up and actually came in even with the testing scores of children without asthma, which is phenomenal. So that's not here, but if anyone wants that, I can get that for them. The next page, 22, for mental health, we just tried to look at how many have been going through mental health and what percentage of the overall mental health they are. You can see Latinos in our community have a much higher utilization rate of mental health than all other organizations. The next page is on dental. This, the page after goes over what we all should know for children on dental. When do you get your first visit with your dentist? When should you be looking at sealants? It really caught me by surprise how things have changed since mine were little. I don't think when mine were little we would have ever taken a child to the dentist at 1. But for our, especially low-income families, they should be getting their child in by 1, right, John? Yes. And then sealants, I think I read an article that said 75% of cavities could be reduced by sealants. It's we just have to get our children in for that. I won't go over page 25 because we've already gone over it. Page 26 is fun because it explains a little bit about what Stephen Black is doing, and I will point out the cute kids. The one on the left is Mary Maven's grandson. The little girl in the middle is just darling. That's why she's in. Not that the other kids aren't cute, I shouldn't say that. Speaker Pro Tem Campos brought her son to the screening. She had some concerns about his eyesight. And then Madison Nguyen brought her daughter, and all these children, their eyesight was good. The next page just shows what the parents will get back, explaining about, they'll get this plus the photo that Stephen Black showed of their eyes, and it will give them feedback on what further testing needs to be done. Page 28 is just the latest obesity data. There was an interesting article in the Mercury News, I think it was yesterday, about U.S. diet affecting immigrants' health. The immigrants that come to this country are living longer than their children are. And it's about the way we eat in this country and the way we lack exercise. On page 29, I'd just like to point out 1 out of every 2 Latino children born today in the U.S. may develop diabetes in his or her lifetime. Page 30 has the key steps to 10 steps to a healthier you. I think the program is phenomenal. They believe no TV for preschoolers. Absolutely none is acceptable. Music, dancing, creative stories, all that is what we should be using with preschoolers. Special education, page 31, you can see, here again, you've got what percentage of the population is a certain ethnicity and what percentage is in special ed. And this is where Kids Connection, we hope, will really help to figure out what is going on before the child gets to school, and whether we have a language issue, a speech therapy issue, which children should be in special ed. 32, let me just say, more often absences in later years. So if a child has many absences in preschool and kindergarten, the pattern gets set, and half of the students who were chronically absent in both pre-K and K were chronically absent in the first grade. And then 45% of the children remain chronically absent in the third grade. This data is out of a report out of Baltimore. The last bullet is a quarter of students who were chronically absent in both pre-K and K were held back a grade within the next 3 years. It's amazing how important it is to attend school and attend school on time. The next page has a little more on the schooling services. Page 34, a little bit more about First Five and their mission and what they're working towards. We put in page 35, because this is what Rachel was talking about, ACE, and making the investment early. And I wanted this in just so we could supply the source if anyone wants to learn more about early education and early prevention. On page 36 is the conclusion. Some programs we didn't talk about. Baby Gateway is a program we've learned we don't need to create all the programs in this county. We are very good at borrowing. And the nice part is when you borrow, somebody else usually already has quite a bit of data you can work from and add to. So Baby Gateway is a program in Santa Cruz. They go in and try and work with the mother early, just after the birth, try and get the baby into Medi-Cal before the baby leaves the hospital. And that makes life a lot easier for the mother or father when they get home to already have the baby in. They learn about urgent versus emergency care. In Santa Cruz, their emergency visits in the first year dropped by 40% by just teaching about urgent versus emergency care and making sure, if possible, that the baby leaves already with a primary physician attached to them and hopefully a first visit. These are people that First Five is funding. We hire within the hospital, so they have no incentive to push a mother one way or the other. It's just already people working in the hospital. And I think we've talked about quite a few community outreach. Many of you are partners on outreach. Emily's group has a 92% success rate. That means when they identify a child, there's a 92% chance at the other end they will come out with health coverage. Now, part of that is knowing the right questions to ask, because when you help a family apply, the area that is the most time consuming and is the area where it's hardest to get done is the application. So what Emily's trying to do with Ernesto's help is make sure when those children get in front of somebody that does applications, they've got their paperwork, they know what they're going into, and they come out the other end of the meeting, the appointment, with everything finished. And Ernesto and Emily follow that child, as I said, until they get a verbal commitment from the family that the family got their Medi-Cal card. I just had to go, I don't know if any of you have gone through this process, I just had to go through it for my son for in-home support. I grew up speaking English. I don't know how people get through it. I just don't. So if you find a child that doesn't have health coverage, it is really important to get them in front of Emily or Ernesto, because they just will not let that child go. And we've even helped people on our board with helping get their children in health coverage. So we'd like to help with that. The last, the back of the cover, or the front of the cover has our board and our honorary board, and then of course the back cover is our sponsors. So I want to thank you all. If you have any questions, we'll be around. I think each year we get more people that are dedicated to children getting to meet here. And so if you want to meet in a social setting, we have a wine event that we put the save the date in front of you. We make the invitation the same every year. We go to the same place. We have La Papillon food because they're the best. And we have these great wineries. Mayor Tate comes with 10 or 12 people in a limo. And everybody is even actually coming and starting to know each other. So it's kind of like, instead of a fundraiser, it's almost like a family reunion, because some people come saying, I want to see those people I saw last year. A big part last year was Kaiser, Irene Chavez, and she says, I'm making all the doctors go. So it's just really, we feed you a lot so that if you have wine, you still can drive home afterwards, because we want to make sure everybody eats a lot of food there. So we want to thank you for being patient for this amount of time. I think Stephen Black was fantastic. I would hope everybody agreed. I think he's around on the phone somewhere. He said you took a big chance on me, Kathleen, but you could tell the first, I mean, any of you would have, the first time you talked to him, said this is somebody we need to have in California. So maybe once he fixes everything in Alabama, we'll get him to move to Silicon Valley. Thank you all.